On this episode of the Ask Mike Reinold Show, we talk about working in the outpatient orthopedic setting, but focusing on neurological patients. We talk about fat pad irritation and how that may reduce your amount of range of motion or mobility of the knee. And then we talk about, wait, don't tell me, the specific adaptations you should expect with plyometric training. The Ask Mike Reinold Show. Helping people feel better, move better, and perform better. Welcome back, everybody, to the latest episode of the Ask Mike Reinold Show. We have a little bit more of a quaint episode today. Is that a good word? Quaint? Intimate.
Like an acoustic show with your favorite rock star. It's just the guitar and
pretty good.
Yeah. Pearl Jam unplugged.
Like we're like a little closer to the camera, like we're zoomed in a little bit.
Hello.
Or a little closer to you guys. But anyway, welcome back. I'm here with Lenny Macrina, Dave Tilley, answering your questions. We got a few nice questions for you guys today. Head to MikeReinold.com, click on that podcast link, and you guys can ask us anything you guys want. There's a nice form to fill out, and we'll get started, right? I mean, it's so intimate. Let's just get
TBT 2014 when the podcast first started.
TBT.
Throwback Thursday.
Throwback Thursday.
Just the three of us.
BRB, I want to close the door.
We usually
LOL.
We usually put this on Thursday,
Yeah.
so this is a what is it? TBT.
TBT.
Throwback Thursday.
To when the three
yeah,
of us
just
just
the
did
three
it.
of us. That's right.
Before all these
I know. Now there's all these extra people. I feel like, let's just get back to our roots.
Mm-hmm.
Mike Reinold unplugged.
Intimate per day of Tilly. So. Anyway, we have Casey in the Sunshine Band K-Cup, Kevin Coughlin,
Casey and JoJo.
Casey and JoJo in the Sunshine Band, Casey K-Cup, Kevin Coughlin from UMass Lowell. I think we're just getting more and more extravagant.
Yeah.
Drew Doobie Doobie Doodak
He loves it.
from the College of University of Belmont.
You're never going to live that down when you go back to school.
And Nikhil Shaquille O'Neal Harani from the Kentucky.
Yeah.
Kentucky.
I was going to say, you're on fire.
I know. It's almost a good episode.
Too good to
right
be
there.
true.
All right, Drew, you gonna exert
Not today.
dominance?
I'm actually
You're not
first
going
today.
first again today?
Ah, selfless, humble leader.
All right,
Alright.
Nikhil, he's going for the assist. He's going for a triple
I just want to
double
say,
today.
Nikki's hair looks great today.
Great hair, buddy.
I showered.
Yeah, it's good.
It helps.
Fantastic.
First up, Morgan from Arkansas. I'm moving to a small town soon where I'll be completing my clinicals and live after I graduate school. Since it is a small town, neuro patients go to the ortho outpatient clinics. I would like to be a neurotherapist in an outpatient clinic. Do you have any tips on how to market myself to ortho therapist in outpatient?
That's a
Interesting
good
question.
but tricky one.
It's actually, I think the tips are easy. No ortho wants to work with neuro patients,
Yeah.
so
Yeah, you
your
gotta-
ability to market to
Yeah,
them.
yeah.
All right, so you are you're going to outpatient clinic, but you like neuro.
Yeah.
And it's a small community, rural town or something like
Yeah.
that, so everybody kind of goes to one place. What kind of neuro do you think that is? Is that
Stroke
like
rehab,
stroke stuff?
maybe
Yeah.
some brain injury.
That's what I was thinking. of.
Spinal cord injury, maybe.
Man, the first thing that comes to my head isn't, but I guess this isn't physical therapy in America at least right now, but like, man, wouldn't that be a great collaborative team?
Totally.
If like the ortho PTs and the neuro PTs work
OTs.
together and the OTs work, instead of saying, well, that's my patient, that's your patient, just saying like, hey, you work on his rigidity, you work on that, I'll work on
ADL,
some of the
like that,
neuro
yeah.
stuff like that, and you actually like kind of half co-treat or something like that.
That's really cool.
I mean, that's the first thing I thought, but that's probably not going to happen.
Hmm.
So to go to your question, I guess, how do you mark yourself as the neuro guy? Man, I think if you just start telling everyone in the world that that's what you love,
Yeah.
you love doing the neuro, and you tell the front desk, hey, give me all the neuro evals, I want to treat those people.
Right.
I think the orthos will be thrilled
Yeah.
to have you take that off their caseload. It's different. And man, I sure hope your boss schedules things different, right? Like that can't.
That's like an hour.
Yeah, that can't be like a 4 people an hour kind of situation. But
Yeah, I think you go to the doctor's appointments a couple times with people, and you meet those few docs that are in the area that are sending people out to outpatient rehab, and once they see somebody so passionate, it sounds like you are and want to be, I think it's a no-brainer. They're going to send you people.
that's
Yeah.
a great idea.
I would also say too, like you can think of the parallels in sports PT. What we do is like we treat a lot of high school, college, pro athletes, but each of us has our own baseball, gymnastics, golf, whatever. I think neuro at the same time, that's a huge field, even in neuro, like Parkinson's,
Right.
stroke, TBI. To stay current on that literature is
Yeah.
so hard. So I would say pick a few things that like you're really passionate about, like working with spinal cord injuries or working with whatever TBIs, and I wouldn't say not treating the other ones, but really focus on a few that you can like dominate, because that's a hard field to stay up with.
Right, and do what you're passionate about, but
Yeah.
also maybe what's in your community, right? So maybe you're seeing a ton of stroke or something like like Dave said, and try to stick to that. But I like it, go to the doctor appointments.
Props to
so,
you, man.
Yeah, you
And then start a
said,
blog.
He's probably not bad. But maybe it's not marketing to the other physical therapists necessarily, but it's knowing that the neuro docs can have a go-to resource, and it's not just like another generic PT outpatient place, and that you specialize in that. I think that's such a niche, and it's such a small gap to fill that I don't think you're gonna have any trouble with that.
No, not at all.
So yeah, awesome. What's next?
Cool. All right, so we have John from Fort Worth. Do you see much fat pad irritation and stiffness with your knee surgeries?
All right,
I think I understood that.
fat pad. Yeah.
I know Lenny's response.
All
I
right,
think it sees us more than we see it.
Let me translate Drew's though for the crowd though. So he said, do we see fat pad irritation after knee surgery? And stiffness. So a fat pad doesn't get stiff, but I get you. But maybe knee stiffness. So fat pad irritation and knee stiffness. So I mean, Len, what do you think? You want to start with this one?
It depends on the surgery. Depends on the aggressiveness of the PT and the doc. The technical surgery, the technical aspect of the surgeon doing the surgery. But so to answer your question, sometimes it happens if the person heals well or they have comorbidities. ACLs, they can get stiff, but I think the key is recognizing it, that it's happening. The end feels different. The pain is localized to the front of the knee, like specifically, because if they're doing a scope, they go through the fat pads when they're going in to scope the knee and do the work. So, inherently the fat pads are now disrupted and they're going to scar down and get a little fibrotic. So you see it, pretty frequently and pretty commonly. The key is mobility, get them moving, frequent bouts of range of motion, prevent it from scarring down too much, because it's going to happen.
Yeah.
Fat pads are highly vascularized.
I have like a sub question because I don't have as much experience with like post-op ACLs, but the time I can see it most common would be if somebody doesn't do motion early, gets a small cyclops lesion, and then the therapist can't embrace reality that like you need to go back to the surgeon and crank on an extension.
Yeah.
You guys ever seen that where it's like
we see it a lot. I don't know, docs are getting more conservative. We're in Boston, and some of them are holding rehab for 2 weeks after ACLs, which is crazy. So the person's just told, do quad sets and just let it heal, and then 2 weeks later you start your PT, which to me is just mind blowing. And the people that I've seen, I've had a couple cyclops lesions. I don't want to blame that, but you know what I mean? There's other factors that could be involved with that, but I think blocking the joint and you're just scarring down early and never be able to get over that hump, and you're fighting it, and by 6 weeks, 8 weeks, you got to recognize that there's more going on here than just stiffness.
So good answers. I think you guys both answered that really well. I'll go back to the beginning and let me ask again. We talked a lot about knee stiffness after surgery. How many times do you think that's from the fat pad? Because we just totally opened it up.
The
question was specific to the fat pad.
I don't think the fat pad's causing stiffness. The fat pad pain is going to cause maybe some guarding by the person who's going to block you from doing range of motion, block you from allowing them to bike, or they're going to be in so much pain they're not going to do their homework, meaning range of motion exercises. It comes down to motion. I think most of the things that we do in PT is about mobility and motion, and then getting the strengthening on top of that. And if they can't move because they're in pain, it's not the fat pads that are physically blocking the joint.
Yeah.
It's scarring, it's capsular, tightening, it's so many other variables.
And that's like a
good
secondary
question.
why you got to get in so early, because I think that a lot of therapists unfortunately like going a little too aggressive day 0 to day 7.
Yeah, definitely.
So if you get somebody in and just like basics, man, like air flush, massage, pain, basic motion, like you can help relieve a lot of that. They just stabbed you with an arthroscope through your fat pad.
Yeah.
Maybe that'll prevent some
And
stiffness.
I've even, in my career, when I was, a younger PT, some people would do so well early on. You're like, all right, let's push it, because I want it. Now they're doing well, and then they get stiff because you've pushed it too much. You've created a swollen knee, or you've created a little bit more pain. And you're almost playing to the person, like, look, we can press this, we can push this even further because you're doing so well, and then you hit this roadblock. So you got to be cautious as well with that.
Well said.
Love it. All right, what do we got? K-Cup.
All right, we got Sean
Is that a
from New York.
Chromebook, by the way?
It is, yeah.
Get it? Chromebook. Look at you.
School required, got to be.
Yeah, is that like part of your? Is that part of your thing?
No, I love it.
Chromebook. Chromebooks are going to be the future.
As a Google shareholder.
Google Drive, yeah.
Yeah, but aren't you an Apple shareholder?
That too.
I'm a Microsoft shareholder.
Hypocritical.
Anyway, sorry. All right.
One pays for the
Chromebook
other.
it away. KC Chromebook K-Cup.
Sean from New York. Hey Mike, loving the podcast. It's a great supplement to my current coursework. I'm currently an athletic training student at Marist College in New York and plan on sitting for my CSCS in addition to my ATC next spring and plan on going into the strength and conditioning realm. My question, what are the expected adaptations to plyometric programming?
Nice. Quick question with a nice intro. I like that. That was good though.
book.
Actually liked hearing about you. That was good. All right, so plyometrics. What are the adaptations that we're doing it for? I think a lot of people confuse plyometrics with like power drills. And there's a big difference between plyometrics and power drills. You know, I guess I'll start and just say the whole concept or the reason why plyometrics are performed, or the reason why we have plyometrics, is to be able to both dissipate and produce force, right? And more importantly, it's about the transition between that application.
Amortization.
Right, yeah, right. So if you go into the plyometrics and you kind of talk about like what is the basis behind plyometrics and stuff, it's about getting that stretch shortening cycle of the muscle. And that, like Dave kind of alluded to, is the amortization phase, which is kind of in the middle. That's from kind of like the catch, right, where you kind of slow down and then you explode back up concentrically. The key to plyometrics is to train the body to decrease the amortization phase. Decrease that, so that way you can transition that dissipation to the production of force as fast as you can. And that to me is the number one adaptation you should be trying to get. Not power output, not your ability to generate force, but your ability to be able to transition from that kind of catch phase to the explode phase. That's the adaptation. Now don't get me wrong, that's going to have subsequent carryover, right? And you will get more power, but that, if you're not focusing on that, then you're probably teaching the exercise wrong, right? What do you guys think?
Yeah, so I just read like a bunch of strength conditioning text writing for the book that I had on like what are the physiological adaptations to it. So it's just like a lot of things we do in PT. There's like you have the neurological side, then you have like the true tissue side, right? So neurologically is what most people think of as like tuning of the stretch reflex. They think there's a lot of central mechanisms of like pre-activation of the muscle, like before you hit anticipatory. So you have a lot of like local spinal reflex changes, but you also, which I was very surprised for, is there's a couple of studies that show hypertrophy of the tissue, the muscular tissue around the tendon with a lot of plyometrics, and that you also have some elasticity, viscoelasticity property changes of the tendon. And it gets kind of tricky because it's like, what's the optimal stiffness? You don't want someone to be so stiff they can't move through a range of motion, but you don't want someone to be so loose they can't absorb, and they have a super long amortization phase. So, but that's like what the research suggests is two parallel effects of plyos.
Nice.
What about mechanotransduction?
That's actually, yeah, that's how you get hypertrophy.
Duh.
It's epigenetically too.
Correct.
Duh.
I'm learning.
Endogenous growth hormone for epigenetic changes of receptors.
I mean, you can't beat that answer. These two right here. I mean,
Awesome, great episode. Thanks everybody. Please head to MikeReinold.com, click on that podcast link and fill out the form. You can ask us more questions. Try to stimulate Dave's brain thoughts as much as we possibly can. We do it. Try to work the word mechanotransduction into your
epigenetic neurobiomechanical.
neurobiomechanical into your thing.
Watch this episode in 2 years when the research comes out as a lit review in PT. We're like, we should be doing this.
I think this is like officially our first catchphrase, I think.
Yeah, it started from 2 years ago.
Yeah,
my first podcast.
Neurobiomechanical.
I was so nervous that
That
I
was
said
your first one?
Yeah, I was like, well, you got the neurobiomechanical changes. I was like sitting
trying to-
between you two, and I was
you
like,
were
oh my
trying to
god,
impress.
I'm terrified of my bosses.
Neurobiomechanical.
throwing big words out.
I think that's a t-shirt.
Exactly.
Oh my
Do
god,
that,
I don't want it. Epigenetic neurobiomechanical.
Hashtag.
That's pretty solid. Anyway, you know what to do. See you on the next episode.